think I'd like to start by thanking the many people who have contributed to the standards and uh, especially to our staff who have worked very hard over the past few months to produce these. And this marks the beginning of our work around implementing the next waiver, which starts on July 1st. So thank you everybody today for joining us. And next slide. I'd like to start with talking a bit about the approach that we took in producing these standards. These standards, the intent is to guide the service delivery through the new waiver. So they are the standards for fiscal year 2022, which starts on July 1st and go through fiscal year 2026, with a caveat that there may be changes for things like if we do a waiver amendment and add services or other kinds of changes, and we would issue amendments to the standards at those points in time. The other approach that we took was to base things on the 3 pillars of possibilities now. And you'll see these concepts and these approaches integrated throughout the waiver standards. The first being the integration and the foundation of person-centered planning, person-centered supports, and person-centered services, a key foundation. The next foundation is our systems commitment to continuous quality improvement. This is a basic tenet of any service delivery, healthcare delivery, that we are able to look at our status through examination of data and be able to make adjustments and improvements based on that. So that's one of the foundations. The next pillar, of course, is community integration, and the services work together to be able to support people's full access to the community. The other approach that we took was to listen to the feedback that we have gotten over the years and recently, and to clarify both the overall and the service specific expectations based on that feedback. The next approach that we took was to align services to make sure things work together cohesively. An example of that would be how employment services, community learning service, and the new community navigator service work together. And by no means is this the end of that aligning and explaining and answering questions about these things, but the standards were written from that perspective. The next slide. So a little bit more on the standards and guiding service delivery. Some key new features that you'll see in these standards. Number 1 being the use of the provider portal, which will be launching soon through our Inspire case management platform. Another new feature is an explanation of how EVV, the verification, is a new feature to our service system. We have added a new quality management section. Quality management was previously embedded in the general requirements, and we've culled that out and added a lot of detail and supports for developing quality management processes and practices in agencies. We have clarified the general requirements section, so examined what was in there and done as much clarification as we can to that section. And the other new feature, and there are more than this, but these are the key ones, is we've added telehealth standards for certain services. When we submitted our waiver application, we got questions back from CMS and got feedback from them about what needs to be included in the waiver itself, and largely reflective of the changing use of telehealth, the increased use of technology during the pandemic. So we've added telehealth standards for key services, and there we have a glimmer in our eye about adding telehealth to several others. So that's what you'll see in these standards. So I am going to turn over the explanation of the agenda and the launching of this training to Jen. Thank you.
Okay, hi everyone, Jennifer La'a with the Community Resources Branch. Here is our agenda for today. So we're going to start with an overview of the standards and some basics in navigating it. Then the following agenda items are the standards sections in order. So the second agenda item is the general requirements section, followed by the third agenda item, which is the new quality management section. And then we're going to talk about the provider requirements section, followed by the service specific section. And then finally on our agenda, we have some time for Q&A. Okay, so next slide. Okay, so first it's navigating the standards. Next slide. And these are just some basics. You know, and all of this, you know, many of you guys know, so I'm just going to repeat it, but the waiver goes into effect on July 1st of 2021, and it replaces the 2016 waiver B3. We submitted the waiver application at the end of February, and we were asked 2 rounds of very detailed questions from CMS. And then the changes were approved by CMS. Our waiver application was approved on May 21st, 2021. During the time of the waiver application, we began to draft and edit the waiver standards beginning as early as March. And then we finalized it and was able to distribute it in the first week of June. And the appendices were distributed yesterday. Okay, so next slide. And you'll notice that in the standards that in the beginning, there's a summary of changes. And so we're going to go through a lot today, but everything that we're talking about is in that summary of changes, which I'll also cover at the end of this. But just know that that's there for you to be able to follow with what we're doing. Also, like I said in the agenda, we're going through the 5 sections so that, again, it's easy to follow. We're gonna do our presentation in that order. And then the appendices and resources are at the end, and again was distributed on June 15th. Okay, so now we're going to dig in to the section 1. I'm going to turn it over to Sandy to start us off.
Okay, so hi everybody, Sandy Kakugao with Case Management Branch. Next slide. So it just to kind of show you what the changes are in the general requirements from the last standards to this one. So for level of care reevaluation, it's nothing that the providers are required to do. So the level of care determination, as all of you know, is required for the admission to waiver and annually thereafter. And the case managers facilitate this process and completes the form. So then again, it's just updating the process of now how case managers are communicating those dates to MedQuest. The second one is the ISP development. As Mary had mentioned, we have added telehealth beyond, the pandemic, and is now in the standards. So the participants have the option to choose ISP through telehealth if they wanted to do so. And it started basically during the pandemic and the public health emergency, but this will be an option moving forward. The next one is the exceptions review process. It wasn't in the previous standards, and it now is, to describe what the exceptions review process is. And the last one is for consumer directed. We've added more information and elaborated. And of course, the fiscal management that we all know of is through Acumen. So that's it for that portion. And I'm now sending it back to Jen.
Hi again. Okay, we're gonna go a little bit deeper into some of these changes that you're gonna see in the standards. And I just wanna provide an overview of where we're at. So next slide. Okay. We really did hear your guys' concerns over the last few years regarding nurse delegation. As many of you know, DDD has convened many work groups, and we've made every effort to listen and try to find ways to work through it in order to address the different barriers related to both the authorization piece as well as the delivery of service. So we identified that we really needed to put a process in place to more consistently identify the needs and clarify the expectations of who is doing what. So in this slide, we listed a few of the concerns in the current or the previous standards. And then on the right, we listed how the new standards might improve the service. So there on the left, we have lack of RN autonomy during the delegation process. We are experiencing low and inconsistent utilization of the service. RNs are not willing to delegate due to professional risk. There's not enough RN TNC hours to perform delegation to RN standards. Agencies and RNs are circumventing service process to deliver care. There's limited monitoring and standards of care for participants' health and safety. So, again, all of this, we really did hear you, and we just want to reiterate that there's just been a lot of conversations and work and trying to get through that. And what we hope to achieve in the new standards are increased RN autonomy during the assessment and delegation process. As you know, DDD funds are not unlimited, but the assessment is done with professional judgment and within reason. And obviously, we all know that this is not to benefit the provider, but is done by the provider because they're the ones doing the delegation. And again, goes back to RN autonomy. You'll also notice that there's some language modification in there from may delegate, or it used to be must delegate, and it's now may delegate. Delegate. I feel like I'm saying that funny. Also, there's an opportunity for enhanced communication between DDD and the agency. There's process improvements to authorization of hours and modifications intended to improve the health and safety by increased utilization of RN TNC service, which is really ultimately our hope to ensure health and safety. Okay, so now I'm going to actually pass it over to Priscilla, who's going to talk a little bit more in depth about the process and the expectations of nursing assessment and delegation.
Hi, everybody. My name is Priscilla from the Outcomes and Compliance Branch. I'm going to be talking about nurse assessment and delegation today. So like Jen had mentioned, the updates to the new standards were based on feedback received. So a key update to the new waiver standards is a nurse assessment by the provider. The purpose and intent of including the nurse assessment by the provider in the new waiver standards is to allow the RN conducting the nurse delegation the autonomy and authority to inform the delegation process. Before we discuss what is entailed in the nursing assessment, we do want to emphasize that all nurse assessment and delegation shall comply with the Hawaii Nurse Practice Act as is defined by the Hawaii Revised Statutes 457. For participants that have nursing tasks during waiver service, a nursing assessment must be completed by the provider RN. The new waiver standards includes language that specify, but is not limited to, what it should be included in the nurse assessment. So these 5 items are based on the 5 rights of delegation and are driven by nurse delegation best practices and also national guidelines. First item is the identification of tasks that may be delegated. So these are tasks that are going to be specific to each individual's health and safety needs and complexity of the nursing task. Next is the assessment of the participant's circumstance. So this may include assessing the participant's medical stability, condition, and situation. The third item is the assessment of the person performing the delegated task. So the RN may consider the person or worker's skill and knowledge for ensuring the safe completion of the task. Taking all of these components into consideration, the RN can then determine the appropriate supervision and monitoring requirements. The last item included is the recommendation of hours by the provider RN. So based on the assessment, the provider RN will then provide their recommendation for hours needed to complete the nurse delegation requirements. And that recommendation for hours will then be reviewed and taken into consideration for authorization by DDD. Next slide, please. So after the nurse assessment is completed, the next step involves the development of the nurse delegation plan. The purpose and intent of the nurse and delegation plan is to promote the health and safety of participants by ensuring that these nursing tasks can be conducted safely. So under the Hawaii Nurse Practice Act, the delegation plans must be completed by an RN, not an LPN. Please keep in mind that the delegation plans will be specific to each identified nursing task and the person or worker performing the delegated task. These plans must meet skills verification, which includes appropriate training, skills check, and documentation requirements. The nursing tasks may be delegated and performed by a direct support worker or CD employee and should always be done in accordance with license certification rules. For example, if you have a participant that receives an RN assessment for tasks that may be delegated during ResHab services, the caregiver must meet the state's delegation requirements, and the task should still be in accordance with license certification rules as well. And this would be applicable to direct care services also. And next, I will hand it back over to Mary, who will discuss quality management.
Thank you. Got my video. So as I mentioned earlier, there's a new section in the standards specifically on provider quality management. Next slide. Because quality management is at the one of the core requirements of the 1915C waiver, what we are doing is making sure that people understand the alignment between what our waiver obligations are, what DDD does internally to manage quality, and what the provider obligations are, as well as what the expectations will be through this new waiver. So I thought it would be good to just lay out how the dots are connected. So every 1915C waiver is required to have a quality system. And what that quality system does is it monitors performance across the system in multiple areas. And it does that through the language of monitoring, which is through data tracking. So multiple performance indicators, data for that is reported on a regular basis. As well, in this middle box is states must maintain a continuous quality improvement process. So you're tracking your performance, but you're also making corrections where that performance does not come up to the threshold of what's acceptable. And for most of our indicators, we have to meet that 85% of compliance on the performance indicators. So that's what this last box talks about, meeting that threshold. And it's a key requirement for waiver compliance. We report things, most of our indicators on a quarterly basis through MedQuest to CMS. And underneath all that, because what providers do is really, for many of the indicators, it's that rubber meets the road. It's on the ground, it's that provision of services. So providers play a very critical role in developing and implementing their own quality systems to monitor quality of care and ensure waiver assurances are met. So it's not enough just to have reporting, but it's really important that people are looking at the level of service delivery, how performance is being measured, and how we're meeting those waiver assurances. So the next slide will show how that kind of comes together. These are the 6 waiver assurances. And I don't know if we've ever presented on this, or at least not recently, to show you how the waiver assurances fit together and what we are doing to make sure that performance is addressed. So the 6 waiver assurances that we have to meet is the adequacy of the service plans, and that's both at the ISP level and the IP level, the qualification of providers, the health and welfare of participants. This is the health and safety arena. And then the bottom row is the administrative authority, how we DDD are meeting our standards for administering the waiver. The next one is ensuring level of care for individual participants are met. And the last waiver assurance is around financial accountability and making sure that there's, for example, no fraud, waste, and abuse in program. So the top 3, the ones in green, are those assurances that relate directly to quality of care. And the numbers underneath them show the number of performance indicators that we do reporting on. So there's 9 indicators, for example, for the adequacy of service plans, multiple areas that we're looking both internally and at in what providers are doing. 9 for qualification of providers and 8 for health and welfare. So that's really the area of focus for quality of care. The undergirding of that, the bottom ones really are more the administration of the waiver and ensuring people meet the level of care to qualify for services. So the next slide is a graphic that shows the DDD quality management system, not all components, but the basic ones. And I think I'll start with the left-hand quadrant, which is aligning values and services. So the mission, vision, ensuring that people are served in a way that will support their vision to have a good life in the community. That's the basic part of our quality management system. The next quadrant on the right is conducting that continuous monitoring. So looking across everything and making corrections as needed. So some examples of that would be the quality of case management services, what we call internal monitoring, the quality of services that are provided, and compliance with standards. That would be another area of continuous monitoring, as well as the health and safety of each participant. And another example of continuous monitoring is what we do to ensure the certification standards are met for adult foster homes. The next component of our quality management system is having that established structure to review quality. So you need to have a systematic process. You need to have your committees that are looking at quality, talking about the data and recommending improvements. And for us, that is all described in our formal quality assurance and improvement program description. So these are all basic parts of any quality system that you'll see in accreditation, in healthcare, and even broader. These are basic components. And then real key is developing that culture of quality, where quality is everybody's business, that everybody cares about and knows about the quality of what is being provided. And what we do is base that on a systems approach that sets clear performance expectations across the board so people know what it is we're trying to achieve. So that's at a glance, the DDD quality management system. And that ties into the next slide, which is the provider quality management program. This is the new called out section in the standards. And we have, again, defined the expectations a little more clearly and stage them over time, because you can't just snap your fingers to develop a quality management program. it does take work, and it takes people building together. So overall, our expectation is that by June 30th, 2024, so the end of the third year of waiver implementation, all providers must have implemented an agency QM program. And we're going to take you through that process. Many agencies already have an established QM program, so it might be refining or building or just implementing that. A lot of programs that have accreditation from agencies like CARF or COA will have a quality management program implemented. And what is this QM program? Well, it's really designed to do a number of things. At its base is using data to identify issues that impact quality of care. So tracking through looking, tracking through monitoring, and being able to use that data to identify where are we off course? What are we doing well that we need to continue more of? The next would be to identify any opportunities of improvement through the examination of performance data and implementing those things, and then evaluating the impact of your improvements. Because sometimes you implement something that may be not quite hitting the problem. So you want to continue to look at, is what we implemented something robust enough to impact quality? So it's that another key classic stage of any QM program is to evaluate the impact of what you've implemented. So again, don't need to know all of this now, because we are going to be providing a lot of technical assistance and training on this. And we're looking at using our some of our American Rescue Plan funding to be able to provide good training individualized for providers. And the next slide is the timeline and the key components. And in the standards, you'll be able to see more of these details. So by the end of waiver year one, the expectation is that you're establishing your structure. Who's the leadership for your QM program? What is your purpose for your QM program? Do people in your agency understand what the purpose is? And identifying some priority areas to be able to look at. And we'll provide TA and training during this, during the years, all of the years. By the end of waiver year two, so that's by the end of June 2023, that's when agencies will do some baseline measurement in order to identify those opportunities for improvement. And it could be around the adverse event plans of actions. These are all things that are requirements anyway. So there's things that are measurable. Another would be direct support professional skill enhancement, the quality of IPs, looking at how good are those IPs and helping people to meet their goals and objectives, how well are they aligned to the ISP, et cetera. And then the other area would be any agency-specific data that are important to your program in ensuring quality delivery of services. So it could be satisfaction data, it could be physical plant data, how well we're meeting the things that are required in your own agency. By the end of waiver year 3, or June 30th, 2024, so a few years out, that's when you'll have that year to look at the opportunities of improvement that you've identified, implementing a project or two, and then evaluating the impact during that year. And then it's a continuous process or continuous cycle after that. But this would be the time to get your sea legs around your quality management program. And if I didn't mention that we'll be providing training and TA, I'll say it again, we will be providing TA and training on QM development. So next, I'm going to turn it over to somebody.
Oh, hi. Hi, this is
Oh,
Eden.
to Eden. I'm so sorry, Eden. I forgot you. And here she is.
Yeah, thank you. Hi, everyone. So yeah, section 3, section 3, the provider general requirements and standards. So yeah, this was formerly section 2 in the previous standards, but overall there weren't really any significant changes. The most noticeable one might be that a lot of the information was just kind of rearranged, because this section houses so much information that, we tried to organize it in a way that hopefully makes sense and has a little flow. But the actual content within this section hasn't changed too much. Next slide, please. So some of the key changes that we wanted to point out. So in this first subsection for general requirements, for HIPAA, a new requirement was added for providers to conduct annual HIPAA privacy and security trainings. Because confidentiality and privacy are such a big part of our work, we felt this was important, both as best practice, but also as the use of technology becomes more widespread. For example, like it was mentioned, the use and availability of telehealth as an option for service delivery has really expanded a lot, especially over this past year. And then, now is part of this new waiver. And then also implementation of the electronic visit verifications, which I think we all know of, and is actually the next change we wanted to mention. So like most of you probably already know, electronic visit verifications are now required for personal care services. So for our IDD waiver, those services include chore, personal assistance habilitation, private duty nursing, and respite. And this also impacts the consumer directed services. So this new requirement actually followed the 21st Century Cures Act that was passed by Congress. And one of the main intentions of this really was to improve program integrity by, helping to reduce fraud, waste, and abuse. So language was added throughout the standards to reflect this new requirement. And we just wanted to also use this opportunity to put out a little reminder. Again, like many of you already know, but we just wanted to remind you to please start implementing the use of your EVV system, whether your agency has chosen to use SAN data or an alternate system, because they are going to be implementing what they're calling a hard edit, and that is scheduled for August 1st, which is coming up so quickly. So that does mean that, any claims that do not have a verified visit after August 1st won't get paid. And then the other reminder we wanted to mention was you should have started to receive what they're calling weekly error reports. I believe it comes from like a strange email. It's like from their partner in Arizona, but those reports will list claims that would have been denied if the hard edits were in place today. And so we just heard from MedQuest this week that they are working on being able to try to, they're working on being able to encrypt the reports so that they can actually include more identifying information so that it'll be easier to look up the errors. So hopefully they'll have that available by next week. But yeah, we do encourage providers to please, take a look at those reports, because hopefully it'll help, identify any problems and so that we can use this time to make any corrections or anything, changes before that actual hard edit date. So, if any providers or anyone has really specific questions about EVV, MedQuest actually has a specific email address that will have the information linked below, or I'm sorry, we'll have it on a slide at the end of this presentation. Next slide, please. So for final rule, there weren't any changes to the actual requirement. We really just updated the language and the standards to reflect the current efforts that we've all started, working together to reach that full compliance. And then the last thing I wanted to mention here was on that provider portal. So the division is preparing to roll out a provider portal, and it is a web-based HIPAA compliant platform that would basically allow for secure transmission of data between each other, between the division and providers. So there are different features of the portal that's going to be phased in over time. But we are targeting August 1st for that initial go live date, and the focus will be on the adverse event reports. So that means that providers will be able to generate and send AERs through the portal, but we'll definitely be providing more information and training as we get closer to that go live date, and then thereafter as each feature is phased in. So yeah, sorry, just another insert for another reminder to providers. If you can please submit the user account forms if you have not done so already. We just wanted, it's just that we wanted to get that information so we can start setting up accounts for any of your staff who need to be able to access the portal. And we just want to make sure that, that we have that all ready before the actual go live date. Okay, so now I will hand it over to Tracy to talk a little bit more about some of the changes in the AER section.
Thank you, Eden. Good afternoon to all of you. I'm Tracy Como with the Outcomes and Compliance branch. So we're excited to share with you that DD is moving to an electronic reporting system for adverse events, as Eden mentioned. So what this means is that providers will be able to create and submit written adverse events through the provider portal to the case manager through Inspire. And like Eden mentioned, we have a target date of August 1st. In the meantime, we're working on training videos for providers and case managers on how to use the provider portal and Inspire for adverse events. There's many benefits for states to move to an electronic reporting system. And I just wanted to share some of those benefits with you. By moving to a web-based system, we're going to be able to get real-time data on adverse events. We're going to be able to track adverse events as a system in real time. We've built into Inspire notifications. So an example would be specific types of adverse events when they are submitted. We built in notifications so other DD staff will be able to be notified of these adverse events, and that will allow the division to respond at a systems level if we have to. We also designed and integrated our investigations and mortality review processes. So we can now link an investigation to a specific adverse event, and we can now link the mortality review to an adverse event involving the death of a participant. Currently, these processes are conducted by OCB and they sit outside of the case management platform. But once we move to the electronic reporting system, all of these processes will now be integrated. Okay, next slide, please. So in section 3.3, entitled Health and Welfare of Participants, these are specific changes that we made. So we added failure to document or incorrect documentation to medication error. So this is not a new medication error. We inadvertently left this out in the current waiver standards. So we are just making sure that it's added to the new waiver standards. We also are clarifying the written timeline. So we're going to change it from 72 hours to 3 days, or the next business day if the third day is a weekend or holiday. And we know that's kind of been a pain point for both providers and case managers around the 72 hours. So we are moving to days. And then we also added tables in the waiver standards to provide you with examples of what those timelines look like for verbal and written. And that's it. And I'm going to now turn it over to Eden.
Okay, thanks. So the next subsection would be on the staff, qualification requirements. So one thing that we added in the very beginning of this section was just a note on how the terms staff and licensed certified caregiver are used. One of the main reasons for doing this was just to try to have a consistent way of differentiating between the two types of workers who deliver waiver services, because there are slight differences in their qualification requirements. So for the purposes of the standards, staff is used to refer to employees of the provider who provide direct service to participants, which can include licensed or certified caregivers who are employed by the provider. And then licensed certified caregiver will refer only to caregivers who are licensed or certified by the state, deliver ResHab services, and are not employed by the provider. The next change was on that list of training topics. It was just updated with these 3 bullets here. The first one actually is not a new one, but we added the clarification that positive behavior support and restrictive interventions also includes the prohibited restrictive interventions. And then we added the civil rights training, which was recently added by MedQuest as a new requirement by MedQuest. And then, like we mentioned before, we added the annual HIPAA privacy and security trainings. Next slide, please. So these next few changes were actually made based on some of the feedback that we did receive. So for first aid and CPR, the trainings, we added the language that the trainings can be completed online or face-to-face. So I believe the previous standards required only face-to-face. So now we added the online option. And then for licensed nurses, providers can now choose to waive the first aid training for the licensed nurses. And then for TB clearance, we just added that language to clarify that that can include TB testing or a TB screening. Next slide, please. Okay, so this slide just kind of points out a few changes in some of the other subsections. So for under the programmatic requirements for the IP, the requirement for an initial IP was removed. So this change was also made based on some of the feedback we received, but also because there was agreement that, we felt that it was important that CMs and participants and guardians actually receive a copy of the completed IP that would include, the details and the strategies, and have an opportunity to review and approve that version in place of an initial working copy. And then the next bullet, we had added this language. So again, this was not a new requirement. This was something that we have been, I believe, talking with providers about during our monitoring visits, but we added the language to highlight the need to make sure that any identified risk and safety concerns are addressed, whether it's within the strategies or as a separate protocol or support that's identified. And then the third change was because of the change to that initial IP, we adjusted the distribution time frame. So it now is 7 business days after the completion of the IP. And so just a comment, so that time frame for completing the IP has not changed. So that still is the 30 days from the ISP meeting and before implementation. And then under the fiscal accountability section, so the requirement for providers to perform an independent audit changed also. So it's still recommended as best practice, but it's no longer required. And then under monitoring of provider agency, so again, this is not a new requirement, but we just wanted to mention because we did revise some of the language in there just so it better reflects the process for when a special monitoring review and investigation might be initiated, and then what the provider responsibilities would be. Okay, and sorry, just a note. So these are reviews or investigations that would occur outside of the regular annual provider monitoring. Next slide, please. So yeah, the last thing I wanted to mention, and hopefully you folks already heard, so, because there were, some notable changes to that fiscal accountability section, actual separate presentation was scheduled. So I believe you should have all gotten the invite. So it's scheduled for June 29th at 1 p.m. Okay. So I will hand it over to Jen now to go over some of the changes in section 4.
Okay. Hi again, everyone. So I am going to bring us home with the final section in the standards. So this is the service specific section, which I'm sure most of you are especially familiar with. Overall, one of the general things that you're going to notice is the format. So everything is now in the table, and there's no longer an operational guide, which used to be at the end of the tables. We've incorporated all those components into the table. So for example, where you might have seen hours of operation at the bottom, if that's applicable to the service, it's going to be in the table. Next slide. Another difference that you're going to find is that there's this telehealth section at the top of section 4. And it's going to address the requirements for delivering services via telehealth. And as we talked about today, the modality platform is shifting in our, and as our world just continues to shift, we are adjusting and learning the new ways of life, and there's no difference for the people that we serve. So telehealth services that are outside of the public health will include community navigator, individual employment supports, and training and consultation. And then I listed some of the limits, which is that is not to be used, telehealth is not to be used to treat emergency needs, as well as not to be used if a participant requires the worker to be physically present. So an example of that is if the participant needs physical assistance. Telehealth must also not be the only modality of service delivery. Participants should have opportunities for integration into the community. And then lastly on here, you'll see person-centered planning. So of course, telehealth must be chosen by the participant and discussed through the person-centered planning process, as well as documented in the ISP. And then during the person-centered planning process, it must be discussed how telehealth will be able to help facilitate the community integration and support the participant to meet their individual and person-centered goals. For now, just as a reminder, for COVID telehealth services, please continue to use the COVID telehealth assessment. So again, this is for the COVID-related services. Next slide. Okay, so I'm going to go through these next couple of slides and talk about some of the smaller changes that don't require a whole slide, but they're still really important. So ADH and CLSG, we removed the annual limit of the 5260. And then for CHOR, PAB, PDN, and respite, we added the language, as we talked about, for these services which are subject to EVV. For training and consultation, it may be delivered and billed concurrently with other waiver services. So it's that same 15-minute period. For individual employment supports, job development, we changed the limit to 80 hours per plan year. Next slide. Okay, for non-medical transportation, we removed the limit that was in there that limited the non-medical transportation to the first 90 days of employment. So that language was lifted. We also added language that the service may not be used to transport participant to and from services that include transportation. So again, if a service includes transportation, that should be used to transport the participant and not non-medical transportation. Private duty nursing. So we remove the requirement that the participant must receive habilitative services. For vehicle modification, so the assessment and the training are no longer included in the service. Assessment and training are now delivered through TNC. And then for crisis mobile outreach, we added clarification that the service must be face-to-face with the participant for more than 50% of the time of the visit. Okay, next slide. With community learning services individual, for long-term community services learning individual supports at a place of employment, the annual assessment is no longer needed to be completed by a job coach. The case manager will complete this. And this is not like a new or separate assessment. Case managers will continue to identify the needs and supports of participants who receive services as determined by the participant, the circle of supports, the CIS, the person-centered planning process, etc. The new standard also clarifies, in order to emphasize participant choice, that DDD does not allow the employer to require CLSI in the workplace to be provided by a specific provider as a condition for employment. There's other things additionally that I want to just mention that comes straight from the standards. It states that CLSI in volunteer and employment settings may not be used unless the setting is competitive and integrated. This is really, really important, and really the main point of employment setting, which must be competitive. Wages must be the same as anyone else doing the same job, and it must be an integrated setting, meaning persons with IDD cannot comprise the majority of the workplace. It may not be used for the sole purpose of transporting the participant to and from a job. It cannot be used to replace the employer's responsibility for supervision, training, support, and adaptations typically available to others who are working that don't have disabilities. And it can't be used to increase the productivity of a company, like solely just for the benefit of the company, which is a little bit tricky because, you know, hopefully we all as employees do benefit the company, but it can't be where they're there just to make money for the company. And it cannot be as a condition of employment where the employer requires the participant to have CLSI with them at all times. Okay, next slide. Here is our new service, the Community Navigator, which we got a lot of feedback on and we're excited to announce. Straight from the standards, the Community Navigator service are designed to strengthen participants' social valued roles in the community and to assist the participant to identify, connect, participate, and fully engage in integrated community activities and resources of interest to the participant in accordance with their ISP goals. So here we have listed just things to kind of highlight about the service. It is an add-on service, so it's not going to be part of the individual supports budget. It is time limited, so it's only 80 hours per plan year, and it doesn't duplicate community learning services. So community learning services, again, can be an ongoing service to maintain, learn, or improve skills in the community, whereas Community Navigator is really that short-term community connector position, and again, not on an ongoing basis. Next slide. Important to note that providers must complete an add-on application to add this service. This is not like any other service. There's different requirements. So again, an add-on application is required if the provider wishes to provide this service. The Community Navigator must be knowledgeable about resources and has demonstrated connections to the informal structures of local community. And finally, there is a training curriculum requirement, but it's at the discretion of the provider and must be approved by DDD. Okay. So next slide. Oh. Here we see the qualifications for the Community Navigator. And it says the minimum qualifications is a bachelor's degree in a human service field and 1 year of experience, providing direct assistance to individuals with disabilities to network within a local community or comparable training, education, or skills. And then on your far right, it says if in place of that bachelor's degree, you can have 2 years of experience providing that specific skill set. And then in the middle, service supervisor, the Community Navigator, also acting as a service supervisor, must have a bachelor's degree. Okay, next slide. So with ResHab, again, you know, DDD really sincerely does want to acknowledge the challenges that providers and caregivers have been experiencing with ResHab. We all struggle between the competing authorities, the competing federal authorities, but we're also really empathetic to the situation while maintaining that we cannot compromise program integrity. So this is the balance that we really had in mind when we looked at ResHab. Next slide. So again, you know, we are all, as stakeholders, as the state, as providers, we're all collectively bound to the fact that waiver dollars are tied to the expectations and requirements of a service. And we all have the responsibility to meet waiver assurances. So those 6 assurances that Mary talked about in the beginning, a lot of times, like she mentioned, we don't really think about that, but we all have this responsibility to meet those assurances and to report on them regularly. So we can all also agree that maintaining program integrity is of utmost importance while continuing to acknowledge the competing struggles that, you know, providers are facing, caregivers are facing. So DDD knows that believe me, we know that we did not solve all of the problems with ResHab, but instead we really just tried to take a step back and take a look at all of the minimum requirements needed, again, from CMS, our waiver assurances, to ensure a quality program, to ensure that quality program integrity. So what we did was we said that the programmatic and provider requirements for ResHab services have not changed. However, we focused on the expectations of the service and made the language less prescriptive on how to meet that expectation. So for example, we removed the language around agency model and shared living model, not because there are no shared living or agency models, but we in the standards wanted to remove that language because the focus is more on the service and the expectation of the service. So how it is delivered does not change what the requirements are. And we wanted to maintain the expectation in order to, again, maintain the program integrity, but give the provider the flexibility to develop how they will operationalize these requirements. Okay, so next slide. That brings me to the end of our presentation, the end of section 4. And before we get into the Q&A, and I see that there's a lot of questions and answers, which we're going to try to get to. I wanted to also just do a plug for the other ways of receiving continued support for the implementation of these standards. Again, as I mentioned in the beginning, there's that summary of changes. We went through a lot today, but again, they're all in the summary of changes, so it's there for your reference. And we're also, you guys have heard about this ARPA funding that's coming from the feds, and it's really an opportunity at this time as our system just continues to evolve, it continues to change, it continues to really try to be reflective of the 3 pillars that Mary talked about, community integration, quality. We really are continuing to move the system towards that direction. And we have this opportunity right now to use some of the ARPA dollars to support providers, support stakeholders, support families as we continue to evolve. So it's a really great opportunity and really great timing with the new waiver. Also, as hopefully you all know, there's ongoing quarterly provider check-ins. So Sandy and I have been hosting quarterly provider check-ins, and coincidentally, we have one right after this and a few this week. So be nice to us. And yeah, we also have the final rule open house sessions, which we've gotten just such great feedback on, such great participation. It's been such a lovely time to get together with everybody once a month. And because it's worked so well, and we've gotten really great feedback, we're actually going to continue to do that. I just want to do a plug and encourage people as you are completing your templates or, maybe are getting some feedback back from the state. Again, this is a process where we really want to work together. I would highly encourage you to bring your specific questions or just come and listen to other people's questions. So